There we go. Yeah, Morgan's got, I guess, a doctor's appointment that she can't make it to, or she can't make it here. But, um, so I actually was in here with this little model of the heart, and I took one of the probes like off of our machines. And was just kind of like doing the different orientations. Like I actually implore you guys to like come in and just do this to get a better appreciation of like the walls and what you're actually scanning when you're in your different transducer positions. And like I was kind of just rotating through and like I was like, oh yeah, it makes more sense now, like, which is the lateral wall and like lateral septal, and then like, anterior inferior when you start rotating through your different views. You get a good appreciation of like, what it really looks like with the heart and what you're seeing on your screen. So,
yeah, I need to practice that because I have a hard time remembering which ones are which.
oh yeah, because that's, for sure gonna like be on your registry. So then once you start looking at the clips and semi-loops of the heart, being able to know, what wall you're looking at and then what vessel, that corresponds to. So I know with like general and vascular, it's a little bit different. Our notch is this side of the screen, but with echo, our notch is actually the opposite side of the screen. So this is going to be, your notch side when you have your view. Unfortunately, everything is switched for us. All right, so if we do it for our standard 4-chamber view, so this side is going to be lateral, and then this side would be considered septal. So when we rotate, 60 to 90 degrees, we're rotating counterclockwise. We're going to get our 2-chamber view. Then our 2-chamber view is anterior and inferior. So this side's now going to be anterior. This side here is going to be inferior. So if, like, you kind of go back to your model, you have your little notch, which is on this side of the heart. So this is lateral now in your 4-chamber view. Then you rotate counterclockwise. So your notch is now kind of pointing up like 90 degrees, and you take it off. So now you have your front of the heart anterior where your notch is on the left side of the screen, and then inferior on the other side of the screen, the inferior portion of the heart behind the heart. And then when we rotate a little bit more, to get that 3-chamber view, we're now seeing more the anterior septal and posterior. So you can kind of just really appreciate it. Anterior inferior and like anteroseptal and posterior. So when we rotate more, here you're going to get your anteroseptal. Anterior septal. This now becomes posterior wall.
Dan, can you please adjust the camera? We can
sorry,
see
sorry.
Okay.
All right. So this side now is your anterior septal, and then you have your posterior wall. Let's see. this way. There we go. So posterior wall, anterior septal. So this is, again, if you think about it, your notch is here. So your notch is up on the anterior septal portion. And then this is the other side, the posterior wall. Facing. So then once like you kind of figure out, what your walls are, then you have to kind of go back in and color in your wall segments for the corresponding coronary arteries. So I know for me, like right before my registry, I drew all this stuff out and I colored it in to really kind of like ingrain it in my head. All right, so 4-chamber, if we start with the right coronary artery, you have a small segment of the basal septum for the right coronary artery. So I'm making this blue. So then the mid portion of the septum can be that left anterior descending, or it can also be a portion, or it can also be the right coronary artery. So this portion of the septum, this mid portion of the septum, I'm going to do green and blue. When we get more towards the apical portion of the intraventricular septum, this is going to be the left anterior descending. So then apex, we have left anterior descending, the lateral wall, we have left anterior descending. Then when we start getting into the basal portion of that lateral wall, the left circumflex can also sometimes feed that. So I'm going to put in here some of that left circumflex. And when I get into my 2-chamber view, large section of it is just going to be the left anterior descending. And then when we start getting into the inferior portion of the heart, then that's the right coronary artery. Maybe I'll bring this up a little bit more. Yeah. And if we move to our 3-chamber view again, this is going to be a lot of that left anterior descending for the anterior septal. In the posterior wall, we can have circumflex. Or also the right coronary artery. So if we kind of go back to like our model of the heart, like you can really appreciate like that left anterior descending artery really supplies like a large portion of that ventricle, you know. So it's the septal, the anterior wall of the heart, as well as going around towards like, you know, some of the lateral portion of the heart. And then, you know, your circumflex coming around, and the circumflex comes back around this way towards some of more of the posterior wall. But you also, you know, have the right one coming off this way that can also feed some of that posterior wall as well. I know a lot of times on the boards, they'll give you this view for sure because it's pretty cut and dry, you know, which artery it's going to be. They may also give you a 4-chamber view where that inferior basal section, you know, is either, you know, dyskinetic or, you know, and there's akinesis, you know, it's not, or hypokinetic. They want you to understand, you know, like the apex typically, you know, is the LAD. And then when you get into some of your short axis views too, so this is, you know, our, at the mitral valve level. So if this is right ventricle, this is left ventricle, this is the interventricular septum. So we know that interventricular septum, you know, a large section of that is going to be our LAD. And we also have a portion, you know, that could be the right coronary. You also have to remember the right coronary, it also supplies the right ventricle. So if you want to go back to your 4-chamber, you could fill this in blue as well. So then we also have a section of the inferior wall. And we have our circumflex coming around this side. We have our anterior wall for LAD. So there are some areas, you know, where you can have either or along the anterior or lateral walls. As well as when you kind of transition between the posterior and inferior walls. So, so again, typically on like the registries, they're not going to give you those gray areas, you know, they want you to know LAD, you know, RCA to really appreciate, you know, those walls. And green. So then over here we have a left anterior descending, again, anterior ventricular septum, anterior wall. Lateral wall, got our circumflex. And posterior wall that right was it, I'm sorry, inferior wall, the right coronary artery. Then down by the apex. Pretty large segment of the left anterior descending. Inferior wall. For our RCA. And then for circumflex. And again, down here by the apex, you can have some, it could be either, you know, the RCA or circumflex along that posterior inferior wall. So, but definitely become familiar with your walls, anterior, inferior, lateral septal, basal septal. This is anterior septal and posterior wall. So posterior, anterior septal. Sorry. Coronary artery disease. I'm going to abbreviate the CAD for the lecture, coronary artery disease. There we go. So CAD is most common. It's going to be the most common form of heart disease. Found in adults. And it results from atherosclerosis of the coronary arteries. Coronary arteries. So with normal ventricular function, we have myocardial thickening. And we have endocardial excursion. So meaning that the chamber is decreases in a symmetrical manner. So chamber decreases in a symmetrical manner.
Dan,
Yeah.
we can't see that side of the
Oh, sorry.
top.
Now we'll zoom out. There we go. Better. So in a normal heart, you know, it's expanding and contracting. So when it contracts, when you have normal contraction of the heart, the myocardium is going to become thickened. So it gets thicker as the muscle contracts. And that endocardial borders, like the inner walls of the heart, they're going to come in together symmetrically. So the chambers are going to decrease in a symmetrical manner. So when you have coronary artery disease, you wind up with regional. So with coronary artery disease, you wind up with regional wall motion abnormalities. Regional wall motion abnormalities. And this is due to ischemia or myocardial infarct. Or myocardial infarct. So with coronary artery disease, there's something called an ischemic cascade, meaning that symptoms start mild, and depending on the level of the blockage, the symptoms, you know, progressively get worse and worse. And there's certain symptoms, you know, that kind of follow each other. So I'll kind of draw like a chart where this is a level of ischemia. Over here we have normal function. So it isn't until a certain point where the coronary arteries become blocked that we start seeing perfusion abnormalities. So at this point, we're not necessarily seeing anything on our echocardiogram. But the first thing that we're going to see as the level of ischemia increases is we'll start noticing diastolic dysfunction. So that's, that's going to be our E to A ratio. And E prime, A prime. So the next thing we're going to start to see now would be abnormal tissue Doppler. Abnormal TDI or strain Doppler. When they do their strain imaging, so abnormal tissue Doppler. And as the level of ischemia continues to increase, the next thing we're going to see now is we're going to see visible abnormal wall motion. Normal wall motion. As the level of ischemia continues to increase, then the patients will develop chest pain, angina, chest pain. And then finally, we'll develop infarct. Put scarring. So resting blood flow remains normal with a coronary artery blockage of up to 90%. With a coronary artery stenosis of up to 90%. That's a pretty big blockage, for a patient not to really exhibit any symptoms when they're resting. So that's why we do the exercise, the stress tests to put stress on that heart. Because during exercise, the demand for coronary blood supply, causes a mismatch. During exercise. There is higher demand for coronary blood supply. Which results in a supply-demand mismatch. Demand mismatch. So it's not enough supply to meet the demand. So if there's a coronary artery obstruction, obstruct, for a period greater or equal to 4 hours, greater or equal to 4 hours. Myocardial necrosis and wall motion abnormalities will develop. Necrosis. So myocardial necrosis, that's tissue death. Myocardial necrosis and wall motion abnormalities develop. But if blood flow is restored, within a relatively short period before necrosis begins, there's some degree of myocardial function will recover. So if blood flow is restored before necrosis begins, myocardial function will recover to some degree. So it may not be perfect, may not be complete, but at least, you'll get some recovery of your function, your LV function. So again, in most cases, if total coronary artery occlusion for 4 to 6 hours, it will result in necrosis. Most cases. This is 4 to 6 hours. Occluded artery flow leads to necrosis. MI, myocardial infarct. Myocardial infarction. So after an MI, there is a period of remodeling. Remodeling. And during this period, the necrotic myocardium is replaced by fibrosis and scar. So, myocardium replaced by fibrosis and scar. So this tissue is thinner. Tissue is thinner. And more dense. And is so because it's more dense, it's unlikely to rupture. It is unlikely. Sure. So an aneurysm occurs when there is a regional dilatation in the area of a scar. Aneurysm. When you have area of dilatation at site of scar.
Dan,
Yeah.
we can't see the bottom
Oh,
part.
sorry.
You're fine.
So aneurysm. Whoops, sorry. So this would be the aneurysm. So you're going to have a regional area of dilatation. You know, so this could be the damaged tissue wall. So you get an area of dilatation. And this area is going to be either akinetic. There'll be no motion, or dyskinetic, meaning it'll have opposite motion of what it should be. In both systole and diastole. This is just kind of like a picture of, like, you know, my LV. So if you try and picture the aneurysm, if the heart's coming in, this area is going to go out the other direction. And when the heart's expanding, it's going to go in the opposite direction. That'd be dyskinetic, or it's not going to move at all. And that's both during systole and diastole. And then we have a list of complications that are associated with MI. Complications of MI. So we have myocardial stunning and hibernation. We have myocardial rupture. Acute ventricular septal rupture. Septal rupture. You can have papillary muscle dysfunction or rupture. We can have the development of neural thrombi. So development of clots within the chambers. Have mitral regurgitation, regurg from ischemia. You also have aneurysm. Or pseudoaneurysm. You can have post-MI pericardial effusion. Right ventricular infarct. And chronic remodeling. Chronic remodeling. So when we have a short ischemic period, we have something called myocardial stunning. So this is with ischemia for about 20 to 60 minutes. So ischemic period. Of 20 to 60 minutes. So function may recover, but not immediately. So a brief occlusion of 5 minutes may see recovery of wall motion as little as 1 to 2 minutes. A brief occlusion of 5 minutes. We'll see a quick, recovery of wall motion. In as little 2 minutes. Then occlusions for 30 to 60 minutes may see wall motion return within 24 to 72 hours. So occlusions. 30 to 60 minutes. Take 24 to 72 hours. For wall motion to return. So this myocardial stunning, the way I think about it is like the heart was deprived of oxygen for a short period of time. So that muscle, it's shocked. It's like stunned, you know, it doesn't really know what to do. So you develop these wall motion abnormalities, you know, it's not functioning properly. And then depending on how long, you know, that myocardium was without oxygen for determines how fast it's gonna, you know, normal wall motion can return. So that's why it's really critical, you know, to 60 minutes. I forgot 0. So that's why it's really important, you know, for not to ignore signs and symptoms of a heart attack. And if patients are able to, you know, take like nitroglycerin or medications to open up those coronary arteries relatively quickly, the prognosis is much better. And with this also, diastolic stunning occurs also. Diastolic stunning occurs. So you can think of this kind of like a mini heart attack, you know, or like if you're thinking vascular, this is kind of like your TIA. You can also have a process called myocardial hibernation. Cardial hibernation. This is a result of chronic hypoperfusion, so low perfusion, chronic hypoperfusion. Of myocardium. And this is a reversible cause. Cause of LV dysfunction. So if the myocardium's not getting enough blood flow due to a chronic, like over a long period of time, you wind up with something called myocardial hibernation. But it is reversible. They could potentially, stents to open up the arteries, stents to open artery. Or bypass. You can also have something called myocardial expansion. So occasionally there's acute myocardial remodeling. Infarcted segments that results in myocardial expansion of an infarcted segment, which results in myocardial expansion. So this usually occurs in the first 48 hours after an infarct. Occurs in first 48 hours after infarct. And this represents an acute thinning of the myocardium. Represents as acute thinning of myocardium. So due to the rapid expansion, and thinning of myocardium. There is no time for fibrosis and scarring to happen. And so since there's no fibrosis, no hardening, this can be a precursor. This is a precursor to free wall rupture, a VSD, ventricular septal defect. And other mechanical complications of MI. Complications. So wall motion abnormalities, wall motion. We use wall motion abnormalities as a marker for the location of the ischemia or infarct. So we use as a marker slash locator coronary artery ischemia for infarct. So we're using our wall motion abnormalities, to kind of tell where along that coronary artery is the blockage, which artery it is, kind of get an idea. I mean, typically they're going to wind up doing an angiogram, to ultimately find out the degree and severity of the blockage and, which vessels are really involved. But us as ecotechs, we use our wall motion abnormalities to try and determine that. So wall motion abnormalities, can be broken up into regional and global. Regional and global. So under regional, we can have qualitative. So this is just kind of like our eyeball assessment. We can say, it's normal, hypokinetic, akinetic, dyskinetic, hypokinetic, akinetic, dyskinetic. We can look for the presence of scar or aneurysm. Scar. Any aneurysm. Then we can do a semi-quantitative quantitative. And that is our wall motion score index. So the reason that's semi-quantitative is because we're still kind of, relying on our eyeballs to look at the structure of the heart and how it's beating and come up with our own, assessment of whether, it's hypokinetic versus, akinetic. And then, by tallying those up, we get a quantitative value. And then we have more quantitative measurements for wall motion abnormalities. So qualitative, you're relying on your eyeballs. Quantitative, you're actually measuring. So under quantitative, this we have fractional shortening. Have cavity area changes. Okay. Under here, we can do our tissue Doppler or TDI. strain Doppler, strain imaging, strain imaging. Then under global wall motion abnormalities, we have ventricular geometry. We have LV volumes. During systole and diastole, systole, diastole. Ejection fraction, EF. You also have under here something called a myocardial performance index. I don't think that's going to necessarily be on there on your registry. Myocardial performance index.
What does that last part say?
A myocardial performance index. Yeah, I just got this like off a chart. So if we use our wall motion score index, wall motion score index, So the left ventricle is broken up into 17 segments. So wall motion score index is based on 17 segments. And we give a score to each segment. Give a score to each segment. And the way we score each segment is we have to grade it first as either normal, hypokinetic, akinetic, or dyskinetic. So if it's normal, it's a score of 1. Hypokinetic, it's a score of 2. Akinetic 3. Dyskinetic 4. So in this little chart here, I'm going to kind of zoom it in. Like you could see, this is like almost like a parasternal short axis view of your ventricle, like kind of like 3-dimensional. And each segment has a little number associated, 17 being the tip of the apex. So you can imagine, how difficult it is to add up a score and give a score for each segment to create a wall motion score. But the way it is, you assign a number to each segment. So say I get, like I do my tally up my score, I get something like, 32 over 17. So 17, if all segments get a 1, all segments are normal, my total is going to be 17. So a normal heart would be 17 over 17, which equals 1. So 17 over 17, 1 equals normal. Oh, I just saw it. Where did it go? The most common assessment of LV function is your EF. LV function is EF, ejection fraction. So many echo labs will use an eyeball approach. Use eyeball approach. This is highly user dependent. Me personally, I think using your eyes to kind of get an idea and then actually, measuring LV, measuring EF, is a much better approach. So at least, you can, if you're calculating something that doesn't look like what your eyes are telling you, maybe your measurements are off, or maybe something looks worse than it actually is when you go back and actually do your measurements. So left ventricular volumes are used to calculate NEF. Volumes. Used to calculate EF. And then the volumes are indexed to body surface area. Or BSA. So before we do an echo, one of the first questions, about after you identify the patient, you ask them for their height and weight, and that gets entered into your preliminary calculations. So you ask height and weight. The echo machine is going to calculate a BSA, a body surface area. So the most common method of calculating F is the Simpsons rule or method of disk. Calculation of EF is Simpsons. I think no. Simpsons rule or method of disk. This and the biplane method is going to be the most accurate. Accurate. For this, we do it in the apical 4 chamber and apical 2 chamber. So that biplane method of disc, that's when we have our endocardial border that we trace. So we trace along the endocardial border. We drop a caliper down. And then the machine is going to kind of make these series of discs across the chamber. So we do this during systole and diastole. And we repeat in apical 2. So this is that biplane method of disc, biplanar method of disc. All right, so we have now determinants of LV function. function. So the first thing is going to be contractility. So how well and how strong does the myocardium contract? Does myocardium so that's its ability to contract. Another determinant of LV function is going to be heart rate. We're going to have preload. And afterload. All right, so with contractility, so the best determinants of contractility are going to be your EF and fractional shortening. Or EF and fractional shortening. So medication like norepinephrine or epinephrine increases contractility. Norepinephrine increases contractility. Hypoxia and acidosis. Decreased contractility. So limitations would basically be things that, prevent us from acquiring a good EF. So like limitations would be suboptimal images. Suboptimal image. Off-axis image. Off-axis. Arrhythmias.
Then I have a question.
Sure.
How is fractional shortening determined? Is it when we eyeball the contractility?
So the fractional shortening, that's actually a quantitative measurement that we do that measures the myocardium
Okay.
as it's as it's contracting. Let me see if I can get a good image of fractional shortening. Actually, I uploaded a bunch of clips for like eyeballing EF onto this week for you to kind of go through. See if I can get a good video for fractional shortening. Let's see. Zoom. So fractional shortening is actually calculated like when you do your measurements, like it's one of the values that'll get spit out when you're measuring your EF. Like here it shows over here, like, your EF and then fractional shortening. So it'll give you a value. Thankfully, it's nothing that, we have to memorize a formula for or anything like that. So you could see kind of here a little better fractional shortening. So it's measuring that thinning of the myocardium during the cycles. The contraction and thickening and thinning as it contracts. So under heart rate, changes in heart rate inversely affect LV function. And changes in heart rate are due to the sympathetic and parasympathetic nerve activity. So changes in jar due to sympathetic parasympathetic nerves. So again, another determinant is then preload. This is the volume of blood in LV at end diastole. End diastole. The way I think about it is preload. It's the volume of the blood, and that's like, the heart's getting ready to send out that blood into the body. So it's loading up, it's preloading before the contraction of the heart. So this is when the chamber's full. So under here, we're going to put something called the Frank-Starling relationship. Frank-Starling. Frank-Starling relation. So basically what this breaks down to is the stronger, actually, I'm gonna say not the stronger, the greater the stretch, the stronger the contraction. So as preload increases, so as put preload volume increases, LV and diastolic pressure and diastolic pressure increases. This results in a stronger contraction. Stronger, more forceful contraction. So I kind of think of this as a rubber band. So the more you stretch that rubber band, the more it's going to want to snap back and contract. So that's basically the premise of this Frank-Starling relationship. So this is what happens in the heart. So as the preload volume, that volume of blood in the left ventricle during diastole, as that increases, the heart's going to compensate by having a more forceful, stronger contraction. But this happens, only up to a point. There becomes a point where the heart becomes so stretched out that this relationship breaks down and the heart is no longer able to, accommodate for that extra volume and create those forceful, strong contractions. And that's when you start winding up with your dilated cardiomyopathy. So we can put also stroke volume increases as this end diastolic volume increases and diastolic volume increases. So there's a direct relationship. So things that increase preload would be regurgitation, VSD, VSDs, ASDs, and fluid overload. Hi, how are you? Good. All right, so then we have afterload. So this is defined as the resistance against which the ventricle must pump. Against which ventricle must pump. So under here we have determinants. Your ventricular volume and pressure. Arterial pressure. We can also put, systemic pressure. Systemic pressure. Aortic impedance. Viscosity of blood.
Then by saying aortic impedance, we mean aortic stenosis.
Sure, yeah, good one, yep. Aortic stenosis. You can have coarctation under here. You can even have, maybe they could have like a mediastinal mass. Mediastinal mass. Anything that's gonna impede the aorta. But yeah, definitely aortic stenosis is that's gonna be our big one. LVOT obstruction, LVOT obstruction. And if we're looking at the right side of the heart, we can also have pulmonic stenosis or pulmonary hypertension. So for right heart, pulmonic stenosis. Pulmonary hypertension. Oh. P, HT, pulmonary hypertension. So then we have some indirect parameters. Parameters for systolic function. So this would be your increased EPSS, increased EPSS, and closure of aortic valve during systole. Aortic valve during systole. So under EPSS, normal is within 6 millimeters of LV septum. With LV dysfunction, EPSS is increased. We could say greater than 6 millimeters. And then we have the decreased aortic valve opening on M mode. So if forward stroke volume of ventricle is decreased, there may be a gradual reduction in flow in late systole. Of flow in late systole. This results in a rounded appearance to the M mode of the aortic valve. Rounded appearance of M mode valve tracing. So basically, all forms of acquired heart disease are associated with some form of left ventricular diastolic dysfunction. So there are 4 phases to diastole. So 4 phases of diastole. So we have isovolumic relaxation time. Relaxation. Early rapid filling phase. Diastasis. and late diastolic filling phase. So I'm just going to abbreviate this isovolumic relaxation time, IVRT. So during this time, there's no filling. All valves are closed. No filling. All valves closed. So this is that point. So the aortic valve, just shut, like we just went through the systolic cycle, left ventricle contracted, pumped out all its blood, the aortic valve shuts. So there's that moment of period where the heart is now just starting to relax, but all the valves are still closed. So blood flow is not circulating anymore, but the heart is beginning to relax at that time. It just contracted forcefully. Now it's going to start to relax and expand. So that isovolumic relaxing time is that period. And then that's followed by the period of rapid filling. And this is directly related to the pressure gradient between the LV and the LA, or LA to LV. Directly related to pressure gradient of LA to LV. Then we have diastasis. And during this part, filling occurs as a result of pulmonary venous flow. Filling occurs as a result of pulmonary venous flow, pulmonary venous flow. And then the last portion is that late diastolic filling phase. Late diastolic. And this is a result of atrial contraction. Atrial contraction. So assessment. So we're gonna do Doppler imaging. Assess the mitral valve flow pattern. We're going to assess pulmonary vein flow pattern. And we're gonna do assess the tissue Doppler. Assess tissue Doppler. Of mitral valve annulus. Do you guys have the chart for like the values for like E prime, A prime? Like we did that, right? In our notes somewhere. Maybe. Like for the mitral valve flow patterns. We can draw them again. So MV flow. It's going to be our E to A ratio. E to A. Just get my book. So. Oh, nice chart. All right, so. So with our E to A ratio, normal was going to be 0.8 to 1.5. So mild was going to be a ratio that's less than 0.8. So we have reversal, E is smaller. EA. So pseudo-normal, again, the value will be similar to our normal, or will be the same as our normal. But with this one, we have to evaluate evaluate our tissue Doppler, TBI. Because tissue Doppler will not, I guess it won't invert. So if our, normal, our tissue Doppler would be inverted of what this is. So we'd expect to see a small E and a bigger A on our tissue Doppler. But with our pseudo-normal, we'll see a bigger E and a smaller A. Because we'll not invert. And then with severe, we have an E to A ratio greater than 2. So we have a big E, little a.
Dan, can you please remind us what E and A slopes represent in this case? It's when we MO the mitral valve, right?
Yeah, so we're emoting, so we're in our apical 4-chamber view. We're Dopplering the flow through the mitral valve. So the E basically is that early diastolic filling.
Okay.
You get that rush of blood coming in. And then you get a relaxation period where you get a little bit of filling from the pulmonary veins. Then the A is basically your atrial contraction, that second kick of blood coming in when the atria contract. So the reason why, when you have severe diastolic dysfunction, you have high atrial pressures. So you're going to get a high pressure gradient. So when that valve initially opens, you're going to get a huge surge of blood going in, a very fast surge, because you have high elevated pressures in your left atrium when you have severe diastolic dysfunction. And conversely, if the atria, they're not functioning well, they're not contracting very well, or you have diastolic dysfunction, say from restrictive cardiomyopathy, where they become large and dilated, you're going to wind up with a smaller A wave. So E represents your early diastolic filling. Your A wave is your atrial kick. Well, I guess also with that mitral valve Doppler, you also have to be mindful of the deceleration times, like deceleration times. for E and A. Do it better. So with that first stage, or mild diastolic dysfunction, this deceleration time, the time from here to here, it takes to go back down is going to be increased. So with mild, it's increased. Deceleration time. So it's going to take longer for you to go down that slope. So you'll have reversal of your E and A and increased deceleration time. When you start moving into grade 2 and when you start moving into pseudo-normalization and then the severe diastolic dysfunction, you start winding up with decreased deceleration times. The pseudo-normal can be, close to that normal deceleration time. But when you get into severe, you're going to have a very short deceleration time between those two peaks. So severe diastolic dysfunction, you're going to have decreased deceleration time. So with severe, it's going to be less than 140, what do we say, microseconds, right? Yes, MS. Milliseconds, right? Milliseconds. With the mild one, we have little E, big A. Mild diastolic dysfunction acceleration time is going to be greater than 240, increased. At least those numbers are kind of not bad. 140, 240. So then the TDI, or tissue Doppler, for normal, we should expect to see a small E, and a larger A. This is E prime, A prime. And do E prime over A prime. Normal. So it's basically going to be a mirror image of what our valve Doppler pattern looks like. when they're mild. You're then going to have reversal. So you'll have a larger E, a smaller A, E, A, prime, E prime. But then this is where the difference is. When we get to our pseudonormal, this is when we could tell, the difference between the two. So we'll still have a larger E and a smaller A. But it's going to be even more pronounced. And when we get to our severe, we'll have a large E and a small A. So E prime, A prime. Can't forget those primes. And then the last thing is our pulmonary vein flow. So we get this in our apical 4 chamber view. Apical 4. Systole, diastole. Normal, yeah. So this is your normal flow pattern for your pulmonary veins during systole diastole, and you get a momentary reversal of flow, which isn't that significant, but you do have some reversal of flow. And then with our abnormal relaxation pattern, there's more during the systolic portion and less during diastole. And then this is that pseudo-normal. So here we're getting increased atrial pressures at this point. So we wind up with more reversal in the pulmonary veins. And we have increased flow during the diastolic portion. And then this is the severe or the restrictive, severe, restrictive. So again, we have a large reversal area as well as much higher during diastole. So mild diastolic dysfunction can also be called abnormal relaxation. And severe can also be called as restrictive diastolic dysfunction. Abnormal relaxation or restrictive diastolic dysfunction. This is your pseudo-normal. Again, it's up to us to just, get the waveforms. Thankfully, we're not the ones that have to ultimately, make these diagnoses and these calls. It's the cardiologist that looks at it, interprets our waveforms. It's important for us to understand, what's going on, being able to differentiate, between normal and pseudo-normal, and how to acquire the images properly. Anyone have any questions about anything? That was a lot. Nope.
Yeah, we just need to digest this. So this pulmonary vein flow we will see on Doppler in apical 4, right?
So, yep, we got our 4-chamber view. So the pulmonary veins are going to come in
Mm-hmm.
here, here, here. So you can, I usually Doppler these because you're more parallel to the flow. You'll get a better tracing. So I'll Doppler
The-
one of those.
Our waveform, right?
Yeah, the waveform. You'll get a better tracing in waveform because you're more direct. You're parallel to the flow. So if you're trying to Doppler one of these guys, it's you're not getting a good. You don't have a good angle on it.
Mm-hmm. So how can we tell between pseudonormal and
So this reversal of flow component is going to be much larger than your normal. Because over here you have elevated LA pressures. So you're getting reversal of flow back into the pulmonary veins. So LA pressures are high. So you're going to get flow reversal, a larger area or a larger amount of flow reversal. As well as the diastolic component is going to be higher as well. These two are pretty similar. You're going to have a larger diastolic component as well as a much larger area of flow reversal.
so is there any measurements or we just eyeball it on the waveform?
No, yeah, we're not measuring it. We're just obtaining a waveform. We're just
Mhm.
Dopplering and getting a waveform for the doctor.